My name is Anissa Mitchell. I'm with PMD Alliance, and today we are going to be having a conversation around managing urinary challenges in Parkinson's disease and Parkinsonisms. We know that this is an issue. I don't know that it gets talked about enough as sort of a non-motor symptom in Parkinson's, and I'm very excited to introduce our speaker today is Dr. Fernando Pagan. He is a board-certified neurologist and movement disorder specialist and professor and vice chairman of the Department of Neurology at MedStar Georgetown University Hospital in Washington, D.C., and he is the director of their movement disorders program. I am excited to have him be a part of this conversation today. He does such a great job of explaining things so clearly. And so he's going to be sharing some slides. I do encourage you all to, as you're listening to the conversation, to drop your questions in the chat box. I will be watching those and occasionally might even interject those questions as they come up with Dr. Pagan. Because I know this is an important topic for everyone, so we will try to get to as many of those as we can. So Dr. Pagan, it's great having you today. I'm going to hand this over to you.
Thank you. I'm sharing my slides. Can everybody see my slides?
Yes, perfect.
Excellent. Well, thank you so much, Anissa, for that kind introduction, and thank you to the PMD Alliance for putting this together. So today we're going to talk about the urinary challenges that we see in Parkinson's disease, and often, we have a lot of these questions in our visits, and still urology doesn't always is in alignment with us because we're just still learning how these challenges do play in Parkinson's, and it's really a result of Parkinson's rather than the bladder itself. So I'll try to explain myself. So the objective today is just to understand what's happening in Parkinson's and why do we see all these other non-motor symptoms. It's just not a motor symptoms. In other words, it's not only a dopamine deficiency syndrome. There's a lot of neurochemicals that are actually involved in Parkinson's disease, and the bladder is one of those. And we're going to talk about the challenges that we see with treating these urinary symptoms in Parkinson's, and hopefully you'll understand what the symptoms are, why they happen, and the different things that we can do to help patients with Parkinson's disease and their caregivers or care partners to deal with these issues. So back in 1817, when James Parkinson described what we now today call Parkinson's disease, was called shaking palsy back then. Really, the main focus was always the motor symptoms, but over time, what we've learned is that there's much more than just motor symptoms involved. So, we know the slowness of movement, the tremor at rest that 70% of Parkinson's patients have, the rigidity. And these motor symptoms and the postural instability definitely they definitely play a role in the urinary challenges, but there's much more than that, than these motor symptoms. So it's both motor and non-motor issues that we definitely do see, but these motor symptoms, as we'll talk in a little bit, can provide additional challenges when we're dealing with urinary symptoms. What we've learned along Parkinson's, and this was based on a paper by Brock, and all these were two pathologists who are married, that they were able to show how these Lewy bodies are propagated throughout the entire brain. So back when I was in medical school, this was the classical slide that they showed us, and they showed us there the substantia nigra, which is the area where the dopamine neurons are, and the panel on top is an individual without Parkinson's, and the panel on the bottom is an individual with Parkinson's. And you can see that substantia nigra, which means black substance, there's actually melanin cells there that protect the dopamine neurons. there's a loss of that area over time. And then if you look at the middle panel, the top one is a person without Parkinson's, the bottom one is a person with Parkinson's. You can see there's a dropout of over 90% of those dopamine producing cells. And inside of those cells, you see the formation of what's known as the Lewy body. And this is you have an over amplification of alpha synuclein in that Lewy body, and this is an aggregate that develops over time that leads to cell dysfunction, ultimately cell death. And what we've learned over time is that this can propagate throughout the whole entire central nervous system. And back when I was in medical school over 30 years ago, just that these Lewy bodies in Parkinson's were just present in the septum nigra was really the tip of the iceberg. What we've learned is that there's a much more diffuse propagation that involves both in the central nervous system and the peripheral nervous system. And it also does involve the autonomic nervous system. And that's what controls the bladder, the autonomic nervous system. And that's one of the reasons why we do see what we quote unquote call the neurogenic bladder. This is part of the Parkinson's complex, and understanding that it's part of the Parkinson's complex and how we can deal with it is really, really important. So this was the paper by Brock that kind of explained how these Lewy bodies are propagated throughout the brain. And what we have learned since then is that it starts in the lower part of the brainstem and the olfactory bulb. So some of the earliest signs and symptoms are definitely smell problems, sleep problems, constipation. But then these Lewy bodies continue to propagate more upward, or what in medicine we call that rostrally. So it starts from quadro-rostral type of distribution. So it goes up the brainstem, and then eventually can involve areas that affect our mood, and further our sleep. So these are the classical symptoms sometimes of Parkinson's: sleep problems, mood problems like anxiety, and constipation and difficulty with smell. It's not until the third stage that we start to see the motor symptoms like the slowness of movement, the rigidity, or the tremor. And then as the disease progresses, it involves other areas of the brain, eventually involving frontal areas, temporal, occipital areas. And sometimes when we start to get that frontal activity, that's also an area where it further can affect urinary symptoms, because the signal that usually happens to us that we got to go to the bathroom doesn't work as well. So when we'll be talking about that a little bit. So the signal from the bladder that usually goes to that frontal part of the brain is no longer happening as the disease progresses. So this understanding how slowly this pathology does propagate throughout the whole entire brain, that involves the central nervous system, but also the peripheral nervous system and the autonomic nervous system. These are the contributing factors to the urinary problems or the urinary symptoms that we often see in Parkinson's disease. So non-motor features have been now well established in Parkinson's. For the last decade, we've really been paying a significant, paying a lot of attention to these non-motor features. And we have great treatments for the motor symptoms of Parkinson's, and we're getting more and more better drug delivery of drugs like levodopa. But there are all these non-motor features, and we're paying a lot of attention to how can we help better Parkinson's disease patients when they're also not only having the slowness of movement, the rigidity and tremor and balance difficulties, but if they have depression, anxiety, psychosis, and dementia or cognitive impairment, the fatigue, the apathy, the sleep disturbances. And when you affect the autonomic nervous system, that causes constipation, that causes your urinary dysfunction that we're going to be talking about today. Sometimes there's excessive sweating, there's drooling. There's also something called orthostatic hypotension or neurogenic orthostatic hypotension, where when you go from a lying or sitting situation to a standing situation, your blood pressure drops. And in addition, you can also see a lot of pain. and difficulty with taste and smell. So these are the non-motor features of Parkinson's that don't always get the most attention to, but the motor features can definitely affect these non-motor features. And sometimes when we start treating some of these non-motor features, we can affect some of these other non-motor symptoms or the motor features as well. So they play hand in hand. So looking at an individual as a whole is really, really important. And when we start to think about treatments, especially pharmacological treatments, we have to really understand those pharmacological treatments, which are appropriate for Parkinson's disease patient, but may not be the same ones that are appropriate for other individuals who have the same type of urinary symptoms, but it is not because of Parkinson's. So I think Parkinson's treatments of urinary dysfunction is more has to be more skillfully thought about, and it has to be really tailored to individuals who have Parkinson's disease. So hopefully that's one of the things I'll be able to enrich you with some great information today. So next time you have to see a urologist, you have a little bit better understanding of what your symptoms are and what are the different treatment approaches that can be used, and which ones are more appropriate for somebody who is having Parkinson's disease, and so for rather than somebody who may have something like a previous stroke or an enlarged prostate, or or they have multiple sclerosis or something else. But for Parkinson's, we have to be very careful with some of these medications. So so again, the non-motor problems that we often see are all of these that I talked about. And we're going to focus now really on the urinary dysfunction, but also how we treat that urinary dysfunction can affect those non-motor symptoms. So always have that in mind when you're seeking treatments. So we see urinary dysfunction in Parkinson's patients at a very, very common. These are common symptoms that we see. 70% of our patients with Parkinson's will have voiding difficulties. One of the most common symptoms is what we call urgency. And this is just having to go to the bathroom very frequently. Every 30 to 90 minutes, you're constantly going to the bathroom. And when this urgency happens at nighttime, when you're supposed to be sleeping, because sometimes I'll see patients, they say, I sometimes get up 6 to 7 or 8 times a night to go to the bathroom. That's called nocturia. And again, this is part of the increased frequency or urgency of having to urinate. During the day is just called urgency. During the night is called nocturia, having to go to the bathroom. Going to the bathroom once or maybe twice is considered relatively normal, up to once. But once you're getting up 3, 4, 5, 6 times a day, there's something going on. And in Parkinson's, we definitely do see this. Other disorders that you can see this urgency and frequency in nocturia, something like diabetes. It does happen a lot in that particular syndrome, especially when sugar isn't well controlled. But when we do see these, we have to figure out why that is and how we can help patients who are having that nocturia, that frequent urination at night, because it affects their sleep. And Parkinson's patients do so much better if they get a good night's sleep. But if they're waking up every 2 hours to go to the bathroom and getting up at night, that can affect their sleep efficiency, and the next day could be pretty tough. The other important symptom is something called incontinence. So one of them is called urge incontinence or overflow incontinence. So if somebody's having difficulty emptying the bladder, that's called retention. So if you're having the retention, not being able to empty the bladder, that can cause what we call an overflow incontinence. It's gotten so full of urine that now it starts to leak out and you can't control it. Urge incontinence is due to the fact that I was talking about, when you don't have that signal anymore that tells you, hey, I got to get to the bathroom, and I should probably get to the bathroom sometime within the next 30 minutes. I'm starting to feel kind of full. I got to get to the bathroom at some point. With Parkinson's, the reason why this urge incontinence happens is when you finally get the signal that you have to go to the bathroom, you probably should have gotten that signal 20 or 30 minutes earlier. So when you get that signal or that feeling that you got to go to the bathroom, you have to go now. So the minute you feel that urge, you got to go. And a lot of times we see patients with Parkinson's that as soon as they get that signal, sometimes they have a mishap where they have an incontinence episode on the way to the bathroom, or while they're trying to lower their pants or unzip their zipper, and that's when they have that incontinence episode, they couldn't get to the bathroom fast enough. And again, with Parkinson's, especially if you're in the middle of the night and your medicines have worn off, it may take some time to get to the bathroom. So it may take you a few minutes just from the bed to the toilet. And again, the incontinence can happen on the way to the bathroom because that feeling that you had to go to the bathroom came too late. And again, that's part of the neurogenic bladder and not having that signal work the way that it used to. And then for some people, they can have pain when they urinate, and that's called a dysuria. Dysuria means painful urination, and that sometimes could also be a sign of an infection. And especially if you're having urinary retention, you can't empty the bladder the way that you used to. It's an incomplete emptying that can cause urinary retention. That can be a perfect setup for a urinary tract infection. And that can cause dysuria, but that can also worsen the urgency and frequency. So urinary tract infections are also part of the urinary dysfunction of Parkinson's patients. So if you're not moving as well and you're having a lot of these issues, we can see a lot of urinary tract infections, or what we call UTIs, urinary tract infections, and this can lead to confusion, hallucinations, worsening of the motor symptoms of Parkinson's disease. So it feeds in a cycle. There's like a snowball effect that sometimes happens with our patients. So these bladder symptoms are really important to discuss with your primary care doctor, your urologist, with your neurologist. And it is important with the neurologist because one of the things that we've learned is that when our Parkinson's medicines wear off, so in other words, you may have heard previous lectures in the past when your levodopa is working, that's when you're on. That's when your motor symptoms are best treated. There's no tremor, you're thinking clearly, there's no brain fog, you feel good, you feel like you can accomplish the things that you need to accomplish. When the medicines wear off, you can see there's more motor symptoms, but sometimes there are non-motor symptoms that get worse. And one of them is definitely urgency. And that's sometimes why we see treatments like, that's sometimes why we see nocturia, because a lot of our patients wear off of their levodopa medications during the night. Most formulations only last 2 to 4 hours, although we've had some improvements in that, and we can definitely talk about that, about some of the things that we're seeing with some of these advanced formulations, especially when it comes to urgency and nocturia. So when we see worsening urgency and frequency, this could also be a sign of wearing off. So that's really, really important. So what are the causes of this? So I've already mentioned some of this. So number one is there is autonomic dysfunction in Parkinson's. So these Lewy bodies are definitely affecting the peripheral nervous system, which includes the autonomic dysfunction. But yet again, the frontal lobe is not working as well to interpret the symptoms or the feelings that the bladder is full and it's time to go to the bathroom. So the autonomic dysfunction that I talked about is also associated with constipation. That's one of the issues that we see. A lot of patients are having these bladder dysfunction, so they don't drink as much, and it makes the constipation even worse. And constipation is usually a problem with autonomic dysfunction. The GI system doesn't move as before. So constipation and urinary urgency and frequency usually feed off of each other, and a lot of patients stop drinking a lot of fluids, which makes the patient worse. And then sometimes because there's autonomic dysfunction, they're not drinking enough fluid. Now their blood pressure is dropping even more when they go from a sitting to standing position, and that's called orthostatic hypotension. So a lot of patients with autonomic dysfunction are having all of these symptoms. So it's really important to talk with your neurologist to really get a handle on to get on the best treatments for this autonomic dysfunction. But controlling those virus symptoms are part of controlling that autonomic dysfunction. And we talked about how the slowness of movement and the dystonia, and if you're off, it makes it even more difficult to get to the bathroom in a timely manner. And again, causing that urge incontinence or that accident on the way to the bathroom a lot of times. And then with the dopamine deficiency, what we've learned is that the back of the muscle of the bladder, it's called the detrusor muscle, becomes really tight when you don't have enough dopamine. So the bladder gets squeezed. So you can have just a small amount of urine, but you feel like you got to go, and you're going to the bathroom a lot. Every 60 minutes you may be going to the bathroom, but you're not really producing a lot of urine. You're just getting that feeling, but that could be a sign of dopamine deficiency or wearing off. So one of the things that we as a movement disorder neurologist could do is that we can enhance our Parkinson's disease medications, especially like the levodopa, and use longer acting ones or deliver it a little bit better with all these new formulations that have recently become available so that patients could sleep better throughout the night. So one of the first things that I usually do is when I see somebody having nocturia is enhance that evening medication and then get them on a more extended release formulation of carbidopa levodopa, and that can reduce the urgency and frequency, and sometimes can help with that retention. And a lot of patients who come into the hospital and get a surgical procedure, and they don't get any of their levodopa or their hold because they get their NPO, nothing by mouth, but before the surgery, sometimes they won't take their Parkinson's medicine, and then after the surgery they can't go to the bathroom, and that can also be a factor when you're worn off, because that first ability to be able to go to the bathroom and squeeze the bladder is skeletal muscle. If that gets dystonic and rigid, then you can't go to the bathroom. So the dopamine deficiency does play a role, although this is a non-motor symptom of Parkinson's. It is related to the medications and related to the dopamine deficiency that we see in Parkinson's disease. So the impact that we see from all of these symptoms, these urinary symptoms and urinary issues in Parkinson's is significant. A lot of times we'll see that patients do not want to go out, or if they are going out, they want to be on an aisle closest to go to the bathroom, and they sometimes these issues, even wearing something like Depends isn't strong enough for some of these overflow incontinence or urge incontinence. So because of these, a lot of patients don't go to social activities, or they don't want to leave the house, and it can affect their personal relationships, especially if one spouse wants to go out to a dinner or go to a play or a movie. The other one's like, no, because of the urgency and frequency, I can't go and sit in a movie theater, I can't go see a play, etc. So there's a real emotional and social impact that these symptoms do affect. And I talked already about how severe the sleep can be affected in these patients. We get poor sleep efficiency, a lot of fatigue, and sometimes that impacts your daily function the next day. Kind of are so tired and have like a brain fog all day long. The sleep benefit of Parkinson's is so significant that when a Parkinson's patient get a good night's sleep, the next day can look like they just got an improvement in their dopaminergic medications. So sleep is very essential. So it's really important for me as a movement disorder neurologist, when I see somebody suffering from severe nocturia, that there's something we have to act, and we have to make sure that we improve that. And this urgency leads to a lot of mobility issues, and there's this fear that you're going to have an accident because of the urge incontinence that happens, or overflow incontinence. And why there's such a big mobility challenge when this is happening, this urgency and frequency, is usually because our patients are off. So going to the bathroom, the patient's balance may not be significant, may be impaired at that particular time because they're having an off period. And all of these issues definitely not only affect the individual with Parkinson's, but those around them. So the caregiver and the care partner, but the family also get affected by dealing with these issues, especially if there's, the laundry is a lot higher because you have to do a lot more laundry because there's several accidents throughout the day. You got to clean up if there has been an accident. So it does cause a lot of emotional and social impact on our patients and their families. So it's something that really has to be addressed by both the movement disorder neurologist and hopefully a urologist. So this is really, really important. How we make the diagnosis is really by history. Sometimes also getting a diary where you look at the frequency of urination, the volumes, how many times you're going. You put that together, honestly, with a motor diary, like how they're doing from their Parkinson's. You would see that these frequency of urination and nocturia are most common when our patients are off. A urologist will often do urodynamic testing to assess the bladder function, and they can identify issues with what's happening with the retention, why the incontinence urgency. A lot of times you'll see a urologist who doesn't really understand Parkinson's and say, the bladder's fine, because it's not the bladder, it's the nerves innervating the bladder that are dysfunctional and the dopamine deficiency. So I'm always very keen to who are patients with Parkinson's, which urologists they're seeing, because there are certain urologists who are really good with neurogenic bladders, and there's others that are better with other types of problems. They may be better with a stress incontinence, which happens a lot with women after having children. They may cough and have an incontinent episode. So those are different than what we see with Parkinson's, with the urgency, the urgent incontinence and the overflow incontinence. So definitely having somebody who understands the neurogenic bladder is better than just a general urologist. But it's always important to rule out other causes. Like you got to make sure that it's not, the urgency and frequency isn't increased just because there's a UTI. So you always want to rule that out. And sometimes some of our patients have a double whammy because there can be an enlarged prostate, or they've had a history of prostate cancer, and because of the treatments that also played a role. But then you add the Parkinson's on top of it, and that could make it worse. So really distinguishing all the different causes is really important, and this is where a referral to a urologist who understands the neurogenic bladder can be very helpful. So as a neurologist, as I assess my Parkinson's medications, I do refer to a urologist to get that to get that urodynamics, and just make sure there's nothing else going on. If they're a male, do they have an enlarged prostate as well that we're missing, that's also playing a role? If they're female, do they also have stress incontinence? Is there bladder prolapse, etc.? There's so many different things that can also play a role in this. So having a proper urologist do an evaluation could be very beneficial. The other thing I also do is I usually enroll our physical therapists to help us out. So there's incontinence physical therapy. We'll talk about that. Really, really helpful. And then we can talk about the different neurogenic bladder treatments. We have to be very cautious with the class of drugs known as anticholinergics, and I'll cause some of them out. So these are medicines that block acetylcholine. And in most people without Parkinson's, you do that. That causes relaxation of a spastic bladder. But with Parkinson's disease, we are already dealing with a cholinergic deficit. So we already have, and our acetylcholine is already low, that this can cause confusion, delirium, hallucinations, worsen the constipation, cause dry mouth, cause dry eyes, blurry vision. So the anticholinergics, we have to be very, very careful with Parkinson's. We'll talk a little bit about some advanced therapies like botulinum toxins, and now there are stimulators that are now available for the neurogenic bladder. And I've been lucky to see a few of my patients get it, and it really has made a drastic improvement in their quality of life. So let's talk a little bit about the incontinence physical therapy. So here's where these are specialized physical therapists that have done training programs in how to deliver the best treatments for incontinence, and it involves exercises. You may have heard improving the strength of the pelvic floor. These are called Kegel exercises that are part of it, but they have a whole set of different exercises that can be helpful to improve the pelvic floor. But in this, remember, Parkinson's is a motor disorder. This is using motor treatment. So these are prescribed motor physical therapists, also are movement experts as well. And they're so important with dealing with this, but they not only have a hands-on approach of improving motor function, they educate patients. There's also behavioral therapies that are part of this as well. So one of the things that can often be helpful is scheduling bathroom visits. Remember, I said how that signal doesn't work anymore. So, and this is what the physical therapist will teach you about getting a routine down. So not waiting to get that signal. So you go every 2 or 3 hours regularly to reduce that urgency or that overflow incontinence. And again, we talked about those pelvic floor exercises. So you're basically really training the bladder again, just like we do the big and loud. We think big, we think loud. This should be called think the bladder. So because you got to take over there because the autonomic nervous system isn't working. And this is what Parkinson's disease robs us of. It robs us of our automatic pilot, whether it's a motor function or a non-motor function. Things that used to happen automatically don't happen anymore. But if we think about them, now we can take control of that body and we think it. So think bladder. So just like we think loud, think big, think bladder. That's that we should recall that incontinence physical therapy, think bladder. That would be terrific, because I don't think enough patients get referred to physical therapy for incontinence. And then there's pharmacological treatments, and this is where we could really help educate our patients. So we talked about the anticholinergics, the big one that's used and would always be prescribed to a lot of our patients, although we've had a reclassification of new drugs that aren't anticholinergic that can help patients. So we're seeing less and less of this oxybutynin. This one definitely does reduce bladder urgency and these spasms, but with Parkinson's, the side effects can be very debilitating and sometimes worse than the urgency and frequency that was happening, because that one, the anticholinergics block acetylcholine. So I would say this is one class of drugs, anticholinergics, we have to be very, very careful with, if not avoid, in a lot of our patients, especially if they're a little bit more advanced in Parkinson's. Just like we have to avoid drugs that block dopamine. So these are dopamine antagonists. We've got to avoid those. So anticholinergics I put here in red because those seem to be kind of like, they were like reflexive for a lot of urologists. But luckily we've had these new classes of medicines that can also relax the bladder. They're sometimes a little bit harder to get from from insurance companies, but they're much better tolerated in Parkinson's disease patients, and these are the beta-3 agonists. And this is one example of one, but there's a whole new set of class of these medicines that continue to be developed that have less side effects than the original first-line antispasmodic medications for urgency and frequency. And then again, I talked about you can use dopamine agonists. These are medicines that mimic dopamine to help improve bladder control, but you got to be careful with impulse control disorders, sleepiness, etc. with these. Or you can use some of the longer acting levodopa medicines. So I talked about the advances that we've had here. So now there's longer acting. So one of the first longer acting medicines that became available was a drug known as IPX066. It was extended release formulation, also known as Rytary. And now in 2024, we got one that's even longer lasting, that can last somewhere between 4 to 8 hours, depending on the individual. And this one was called IPX203. And again, a true extended release formulation that binds to the small intestine and slowly dissolves over 4 to 6 hours there. But a fourth of it is immediate release. And this could get people better sleep because they stay on longer. And this could help reduce the urgency and frequency if you use medications like this. So this one now is known as Crexont, and that's an acronym for can really extend on time. So these are the medicines that can really enhance our patients to be able to sleep throughout the night. And now we have these pumps that deliver medicine continuously throughout the day and can be used throughout the night as well. So that's the new Violet pump, which is a carbidopa levodopa pump. And that's one of the things I've seen in my clinical practice is that patients have better sleep because they're not waking up so much to go to the bathroom, because they stay on throughout the night because they're getting the carbidopa levodopa subcutaneously throughout. It's almost the same technology that we've seen with diabetics getting their insulin. And then lastly, there's a new one called Anapgo, which is a very potent dopamine agonist that mimics that will mimic the action of dopamine. And this one crosses the blood-brain barrier very freely. And this one can also help maintain patients on and improve that bladder control. And I've seen that happen as well with our patients. And then the last one that I put in yellow as a caution that urologists will often do to relax the bladder, the neck, and prostate. So a lot of patients with a benign prostatic hyperplasia, so enlarged prostate, they'll be given a drug called tamsulosin. I put that in yellow because one of the biggest side effects of that is that it can cause orthostatic hypotension. It can lower your blood pressure and go from sitting to standing. So a lot of our patients already have autonomic dysfunction. So I see sometimes a lot more falls, lightheadedness, really being tired. So I put that one in yellow. So the red one is I would recommend to avoid. The yellow one, be careful, especially if you have orthostatic hypotension. But these are good to understand these classes of medicines, to also discuss with your neurologist as well as your urologist. And then some of the advanced treatments that the urologist can offer when the medical management doesn't work so well, or you're still suffering a lot. I still think always the physical therapy for incontinence will be beneficial to some extent, or really to a large extent. But additional things that could be done is the use of Botox or botulinum toxins. You can inject that detrusor muscle, and that relaxes the bladder. And sometimes that's done about every 6 months. It is invasive to do. It has to be done by a urologist, and it is a procedure. The newest thing is a sacral nerve stimulator, and there's 2 companies that make this. And this, by stimulating the nerve, is called the pudendal nerve, and this nerve can relax the bladder, and it does improve the symptoms of urgency and frequency and the neurogenic bladder. And then sometimes for real severe cases, surgical interventions will have to be done. If you notice, I did not put any use of any types, and this is something that's done quite often, the use of catheters. The urethral catheters are very can really increase the frequency of urinary tract infections. It's just a matter of time using these. So I try to avoid. Sometimes for real severe cases, the urologist will do a suprapubic catheter or do some bladder augmentation type of surgery. And again, maybe a little bit less likely than having all those other external catheters, but these are things that can ultimately increase the number of infections, causing more UTIs, confusion, etc. More patients sometimes being significantly bedbound. So I would avoid the use of external catheters as much as possible. So we're seeing a change there, and keeping the area dry is very important, because if a patient isn't moving and they develop a decubitus ulcer, is also an area where we have problems of further infections. So lifestyle adjustments need to be made. So sometimes our patients will limit the use of just liquid in the evening. But again, always there's a risk for orthostatic hypotension. Sometimes internists and urologists will use a hormone called desmopressin, which will increase water retention from the kidney, and therefore decrease the formation of urine. So that will decrease the urgency and frequency of our patients. And again, I talked really at length already about optimizing the Parkinson's disease medications and using our advanced Parkinson's disease medicines to improve that urgency and frequency and that nocturia, so our patients don't have that sleep dysfunction. Our caregivers and our care partners are really important. Attending a lecture like today, very important that you're getting education. You're now aware of where you can look for support. This is support groups provide great amount of support, but also if we haven't employed physical therapy or occupational therapy, that could be very important. So occupational therapy can help us getting us improving the bathroom access, make sure the bathroom is safe. 60% of all falls in Parkinson's disease patients happen in the bathroom, because they're going to the bathroom, they have an accident on the way and they slip and fall because of it, or it just their mobility is impaired because they're off. So having an elevated toilet is important. Having good bars around the toilet to be able to sit down is important. But sometimes just there's incontinence products that are amazing. They're like super soakers, better than Depends, so that it doesn't get all over the place, and you know that you're going to have some ease of mind that, okay, if I don't get to the bathroom, I'm not going to make a mess anywhere, and I can just change it. So this is where occupational therapists can talk to us about all the different incontinence products to make our life easier and the bathroom access easier. Sometimes we'll get a bedside commode, or we'll get we'll get a urinal for patients. But definitely getting that emotional support is really important. That we're here for you, and there are things that we can do. So there's always something that we can do to help improve your quality of life when you're dealing with these urinary issues, because we want to make your life easier. We want to make it better. We want to improve the sleep, and the other thing we want to do is we want to prevent those urinary tract infections, because when you have these issues, there's a lot more urinary tract issues, especially infections, that can make the Parkinson's worse and the mobility worse, and then that caregiver burden can increase, or the family. We want to be able to help you as much as possible, but there are things that we can do, and we can work together to get those things done. So I hope, in summary, you've learned about the issues the urinary issues that we see with Parkinson's disease. We got to get you to the right person to make sure that we make the proper diagnosis and to give the appropriate treatment options. We avoid those medicines that can make the life a little bit worse. And there's continuing research that's ongoing to get better medications and better treatments, and hopefully be a little bit more proactive in the future. So I hope you learned a little bit something with my lecture today, and I'd love to open up for questions, and happy to answer questions.
So thank you so much, Dr. Pagan. You covered a lot. It was very thorough, but we do have a few questions, so I'll try to get to as many of them as possible. I wanted to talk a little bit first about UTIs because I know that is something that a lot of older folks, even without Parkinson's, deal with. So, can you just spend a minute talking about what UTI looks like in an older adult versus maybe someone younger? I've understood that it doesn't always come with the same symptom presentation. Maybe it doesn't necessarily have pain or painful urination. Is that true?
That is correct. So a patient with Parkinson's, a little bit older, one of the first signs it says they may be fatigue. It may be brain fog. They're a little bit more confused than they normally are, and they weren't that confused. It could present with a hallucination, and there may not be any pain in urination. There may not be any fever or anything going on. But if you don't act, eventually it can continue on, that then you do see a fever, and then you can see hypotensive. So you want to act as soon as you start to see something's a little bit off here, and it could be just as a slight increase in the frequency of urination. Have a low threshold, especially in patients with Parkinson's who may be a little bit older, that they do have a urinary tract infection, because it doesn't always present with a fever and and pain with urination. But when that fever or that pain in urination finally does show up, it may be too far gone, and you're ending up with a hospitalization and potentially an intensive care unit stay. So it's really important to have a low threshold when things just don't seem right, and the individual has been having a lot of these other issues like urgency and frequency or retention. We got to make sure we're not going down the urinary tract infection route. And now you can check somebody's urine at home. They sell these kits at CVS to be able to check for a UTI. So if you suspect it, you can be able to do it. And my mother has significant memory issues and Parkinsonism, and we check it as soon as things aren't looking the right way. She may have had a few episodes where she may have had an incontinent episode, so we're able to catch it a little bit earlier because there's a lot more tools available to us than before. But definitely, if you have access to a primary care, checking it uh, earlier rather than waiting for it to brew there, because once we really see that it's a UTI and it's far gone, it usually can get quite severe pretty quickly in our patients with Parkinson's disease.
Kind of related to that, I wanted to talk about how that might be complicated by cognitive changes in someone. So if someone's experiencing mild cognitive impairment or even a little worse and a diminished cognition, how does that impact the identification of symptoms or the person's ability to share those symptoms with loved ones, or maybe how hygiene might be impacted, which could relate to that? Could you touch on that a little bit?
Yeah, yes. So if somebody does with Parkinson's, you can see fluctuations in cognition. So there are periods where somebody may feel a little bit more foggy brain, little periods of confusion, especially if they have Parkinson's disease cognition. But if for now you're seeing that fluctuation in cognition or that brain fog or that confusion now is just lasting all day long, you're not getting any moments of any improvement, there may be something brewing there, and that's absolutely correct in this. So that you're not always going to get the complaint that I'm having pain in urination, like dysuria or a foully smelly urine or a change in the color of my urine, etc. That may not come from the patient at all. So again, having that low threshold when there is a significant change in behavior, especially confusion and hallucinations, one of the first things that we usually recommend when we hear that there's been a change in the mental status of the individual, we automatically get a urinalysis on that patient. Yeah.
It's good. And I'm curious, are urinary issues more prevalent for somebody that has an atypical Parkinsonism?
So I think it happens in all of the Parkinson's and atypical Parkinsonisms. What with the atypical Parkinsonisms, the disease progresses a little bit quicker than typical Parkinson's, so it may present a lot earlier in the disease. So for some of our Parkinson's patients, these non-motor symptoms of urgency and frequency may not happen until 10 or 15 years into the disease or when they're having those motor fluctuations, but it can happen already within the first few years with somebody with an atypical disorder, especially if we're dealing with something like progressive supranuclear palsy or multisystem atrophy. You may see it a lot earlier than you do with a typical Parkinson's disease. But you can see it across the board that neurogenic bladder is very common among both typical and atypical disorders.
So, there are quite a few people out there that don't have care partners. They're flying solo. Do you have any recommendations for someone that might not have someone that's kind of watching over them and checking for changes and managing
So
these things?
So for the person that's flying solo, we always have to find our support groups, where's our support areas. So definitely, if you're already starting to feel periods where you know that brain signal to go to the bathroom isn't working as well, you're having that urgency, etc., making sure that you start to get those referrals to physical therapy and occupational therapy. I think that would be very helpful, making sure that you have access to a good urologist to do the proper workup. So working with your neurology team treating the Parkinson's has set that support group. Hopefully there you have access to maybe an outreach coordinator who could guide you. A lot of Parkinson's uh, um, uh, uh, um, Parkinson's foundations around the country can steer you to who is good locally for you to be able to do that. But having that in place, being a little bit proactive can be beneficial, because if you start to employ a lot of these techniques earlier rather than later, you can prevent a lot of these urinary tract infections, the complications that occur with not being able to sleep, etc. So that's really important.
Speaking of prevention, is there anything that actually can help prevent UTIs, such as supplements, probiotics, cranberry? Does any of those things help at all?
No, I think most of them are theoretical. The most important thing is to make sure that you're having proper bladder emptying. So that's why working with a urologist to make sure. Sometimes the urologist will recommend some supplements. I've heard things. I've heard cranberry juice is good and bad, both from different urologists. So I think all the supplements and probiotics. It's very the data is all over the place. For people who are having severe urinary retention, sometimes the urologist will order some very low dose, what we call prophylactic antibiotics, and that's still kind of controversial, but sometimes a person may have had multiple admissions into a hospital because of the bladder issues, that they will get put on some low dose antibiotics to prevent it. But that's where a lot of our research is really going to be important, and those are some of the active research trials that are going on. What are the there's probiotics that are good, and there's some that are bad. Which ones are the best ones, etc. And definitely diet can play a role. And what are the good foods to be able to eat to be able to reduce it, especially if you're somebody who's prone to kidney stone. Kidney stones diet is very important. So these are things that are in active research, but there's nothing really. I mean, every day you see all these supplements on the television promoting these things, but they're not regulated, and they really haven't undergone the classic clinical research trials that we use in traditional medicine to really prove that something is beneficial. So you have to always um, really inspect who's sort of like that drug Prevagen. The one study they quote, they did. and it was funded by them. So it's you. And when I read it, it doesn't even use any of the standard clinical trials that data points that we use when we're looking for cognition. And they have a look asterisks on the research paper. None of the patients had cognitive impairment, but they're talking about how it improves cognition, but not for people with cognitively impaired, but they really promote it to people who are cognitively impaired, but nobody in their study had cognitive impairment. So so you got to be careful with things out there.
Awesome. Well, thank you. And I know that you talked a little bit about pelvic floor therapy. I know that it was dropped in the chat in case you guys missed it. We did have a conversation about pelvic floor therapy with Erica Vitek. And so if you want to save your chat, I think Kiana put in the chat how to do that. You can get that link, or you can go to our video library and check that out, because it gets into depth of what they do in pelvic floor therapy. So I appreciate that. Dr. Pagan, this has been really, really helpful. I know we could probably talk for another 30 minutes at least on some of these questions, but I think you did such a thorough job of overviewing all of the things that can occur, why they occur, treatments that are available, and all of that. So thank you so much for taking the time and sharing your expertise.
Thank you so much for having me here. Everybody, hopefully spring is around the corner for everybody. So have a great end of winter and hopefully early spring for everybody. Take it easy. Nice to see you.
Well, we're going to give you the wave of gratitude instead of clapping and being really loud. So thank you so much.
Thank you. Thank you. Bye-bye.
Have a great day.
Bye-bye.